Well, greetings everyone, and welcome to the EKG case for the week of November 3rd, 2014. This week we've got a quick case. Actually, it could be a little bit confusing to some folks out there. It might be really easy to others. It was a source of a bit of confusion to some physicians taking care of this patient. Fortunately, no adverse outcome. Anyway, here's the case. This was sent to me by one of our second-year emergency medicine residents, an outstanding resident, Dr. Maita Hausendefeld. She is a second-year emergency medicine resident in our program. She did not actually take care of this patient, but she happened to be working when the patient came in, and it sounded like an interesting case, so she brought the case to my attention to share with everybody out there. It is a 70-year-old man that presented to the emergency department at a peripheral hospital complaining of chest pain. Now, he had really no other concerning symptoms. He was fairly stable. He was tachycardic, but hemodynamically stable, maybe plus minus palpitations, but he was looking pretty good. He does have a history of coronary disease, and because his heart was tacking away at a rate of about 130, he got a quick 12-lead EKG, and here it is. Now, this is a case where it's worth hitting that pause button on the iPhone and iPad or computer, whatever it is. I know I say that all the time, and I know there's a lot of cheaters out there who don't do that, but for all you people out there, just go ahead and hit the pause button, take a good close look at this, and try to figure out what is going on here with this particular EKG. All right, go ahead and pause. And we're back. Hopefully you didn't cheat. If you did, then, well, I don't know what to say to you. Anyway, moving forward, the thought with this particular case was that this patient had WPW. He had sinus tachycardia with WPW. Now, the reason for the thought of WPW is because if you look at these precordial leads, and I'll blow that up for you, it sure as heck looks like this guy's got some slurring of the upstroke. He's got some delta waves out there, and maybe he's got some P waves up there. The P waves are a little bit tougher to see. Maybe some inverted P waves in these leads with some slurring of the upstroke of the QRS complex. So the slurred upstroke or delta wave was thought to be essentially significant for WPW. And then if you look out there at some of the inferior leads, it looks like maybe the guy's got some P waves, and maybe there's some short PRs in there. But it was really the delta waves that swayed the physicians into calling this WPW. All right, so let's digress for just a moment and talk about WPW. The big question that came up in this particular case was, how are you going to treat him? He's got sinus tachycardia, and or maybe this is SVT, that orthodromic SVT, or I don't know. What do you do? How are you going to treat him? Questions came up about, well, should we give him some beta blockers and slow his heart rate down a little bit? If he's tachycardic, are beta blockers safe in WPW? This is not a fib, but is it okay to use AV nodal blockade with sinus tach or orthodromic SVT? Anyway, let's digress and talk about WPW. Now, remember that there's actually a clinical triad for WPW. Everybody always thinks of WPW anytime there's any slurring of the upstroke of the QRS, the initial part of the QRS complex. If the initial part of the QRS complex is slurred, people automatically say, oh my gosh, that's a delta wave. It's got to be WPW. And I'm here to tell you that delta waves or slurred upstrokes are very non-specific. Don't make conclusions based on what you think is slurring of the upstroke, because if you look carefully, you'll probably see a lot of people's EKGs that have some slurring of the upstroke. WPW should only be diagnosed when the patient in sinus rhythm has a short PR interval. There's also a slightly wide QRS complex, kind of making a mess there. Remember there's a triad here. Now, slight widening of the QRS complex, that can be a little nonspecific. Delta wave, slurred upstroke of the beginning part of the QRS, very nonspecific. This is the very important thing that you've always got to look for. There's got to be a short PR if you're going to call something WPW. And if you look back at this 12-lead EKG, is there a short PR anywhere? Yeah, there's delta waves, but let's take a closer look at the inferior leads. And what exactly are the P waves that you're calling associated with a slurred upstroke? Are those P waves? Well, maybe those are P waves, and maybe there's a little slurring up of the upstroke. But as one of my professors in medical school, actually residency, used to say, Dr. Edward Chung, a master of electrocardiography, is a cardiologist who published probably 80 books on EKGs. He used to always say that whenever you're looking at a 12-lead EKG, you've got to look up, you've got to look down, you've got to look all around that 12-lead EKG. All right, look everywhere, look carefully, look at the T waves, look at the QRS complexes, the Q waves, ST segments, look everywhere. Take an extra 10 or 15 seconds and take a good close look at that 12-lead EKG. And when you do, well, maybe those are inverted P waves. It's a little unusual to have inverted P waves in the inferior leads, but what the heck are these things? Those are T waves, maybe, inverted T waves, but are they mapping out with the P waves? Yeah, they are. If you get your calipers, they map out perfectly. And if you look in some of the other leads here's AVF, they map out very nicely as well. And that was missed, actually. The physicians taking care of this patient didn't see that. They thought this was WPW because of that slurring of the upstroke, and I guess didn't look carefully enough. Mike actually picked up on this pretty quick. And, one of the reasons I think so this turns out to be atrial flutter, right? One of the reasons I think that atrial flutter often gets misdiagnosed and missed is because in atrial flutter, the flutter waves or P waves in the inferior leads tend to be inverted. And our eyes are very good at picking up inverted flutter waves, picking up upright P waves. But when the P waves become inverted, our eyes don't tend to pick them up very well. So in fact, one of the things that I like to do when I'm even debating slightly the possibility of flutter is I'll take that EKG and I'll actually flip it upside down. I try to do that when no one else is looking, because if they see me flip the EKG upside down, they'll think I've lost it. But I actually do that just because I find it easier to identify P waves when they are actually upright. So here's the same EKG. When you flip that EKG upside down, now take a look at how easy it is to pick up the P waves. Once you flip it upside down, the P waves become upright in the inferior leads, and now I think, it's just my opinion, but I think it becomes very, very easy to pick up on these flutter type of waves once they go upright. And you can actually see it out here in the other leads as well. So whenever you're debating the possibility of flutter, take that EKG, flip it upside down, take a look in all of the leads, and those P waves, which are now upright in the inferior leads, will suddenly become much, much more obvious. So anyway, this is actually atrial flutter with 2-to-1 conduction. There's no WPW, and the whole reason for that slurring of the upstroke is probably because the flutter waves were fusing into the QRS complex, making it look like there's slurring of the upstroke. There's no WPW here. This is just nothing more than just plain old run-of-the-mill atrial flutter with the rate of 130. And by the way, that's another pearl there. We've talked about this before. Whenever you have a heart rate of 150 plus or minus 20, in other words, when you've got a neurocomplex tachycardia of 130 up to 170, be very paranoid about the possibility of atrial flutter. All right, so that's all that this was, and there is no reason to withhold beta blockers, calcium channel blockers, or anything else. In fact, as I recall, one of the cardiology fellows who saw this also was swayed by the slurring of the upstroke and thought, maybe this is WPW, maybe let's just let it fly, let it go until we have a little bit more information about the patient. And that was unnecessary. This is just atrial flutter, no worries about WPW. So just some quick take-home points. Let's do a quick differential before we leave this. When you see a narrow regular tachycardia, there's only 3 possibilities: sinus tach, SVT, and atrial flutter with 2-to-1 conduction. How do you tell the difference between these 3? Look for atrial activity. Look in all the leads. Look up, look down, look all around. Look everywhere for atrial activity. And sometimes you'll see that atrial flutter type of activity. Atrial flutter, by the way, and this is studied, this is published, atrial flutter is the most commonly missed tachydysrhythmia. And the reason why a flutter is the most commonly missed tachydysrhythmia is because people don't follow Dr. Chung's rule. Look up, look down, look all around, look everywhere for flutter, look everywhere. And again, a common rule, one of the reasons that people miss this is because they forget this rule. When you see narrow-complex tachycardia with the rate of 150 plus or minus 20, you've got to be paranoid about flutter because it is so easy to miss. Look in all of the leads for flutter waves whenever you've got a narrow-complex tachycardia at that rate. Don't miss flutter. Don't misdiagnose it as WPW. Don't misdiagnose it as sinus tachycardia. This happens all too often. Again, you can't say this often enough. When you see a rate of 150 plus or minus 20, you've got to be really, really, one more time, really on the lookout for atrial flutter. And that's all that this patient had. So hopefully those are some simple points that will help you along the way. I hope this case was helpful. And my thanks to Maita once again for bringing this case to my attention and sharing this case with all of you. Hope that case was helpful, and I look forward to talking to all of you next week. Bye for now.
Hello everybody, boys and girls, Dr. Carlo Oger, emergency physician for edxitvideo.com. First, I want to thank this patient and his family for allowing me to record this video. This is a procedure that's not often done in the emergency department. I'm going to go ahead and describe what I'm doing now, and then I'll go through why is this rare in the emergency department. As you can see, I have a handheld portable ultrasound. This is called a V-scan. I have video just about the V-scan with a review of it. Anyway, the reason we're using the ultrasound in this case is to find the spot where most fluid, or the biggest pocket of fluid that we can. This patient has ascites, which is fluid within the abdomen caused by non-alcoholic cirrhosis. Patient has some medications that might have induced some liver problems, and since then he's accumulated fluid in his belly enough to have it drained about once every 2 weeks. It happened that it was a weekend and he couldn't get to the outpatient center when they do this, so he couldn't breathe because his belly was so distended, pushing on his lungs, pushing on his abdomen. He couldn't eat because his stomach felt full. So anyway, the ultrasound finds the biggest spot of fluid, and then we clean iodine like we've described in other videos to make sure the area is nice and sterile. Now this is a sterile procedure, so we want to kill all the bacteria. We're going to set up our sterile field. I'm wearing a hat, I'm wearing a mask, I'm wearing sterile gloves, I'm wearing a gown. The whole works because this got to be a clean procedure. Introducing bacteria into the abdomen can cause peritonitis and infection, and in a patient who has no problems right now, that would be really, really bad because it was totally induced by us. So this is our sterile field. We're going to make it a little bigger by adding another sterile sheath. And this is a second kind of wipe, not iodine, but chlorhexidine. And it's another kind of skin disinfectant. This is my second sheet to add to the sterile field. Make sure nothing's touching non-sterile area. I was telling the patient there not to move his arm, because then when he moves his arm, he moves my sterile field, then it might get contaminated. Now this is the lidocaine. We're going to numb him, and this is like any other numbing. Just inject, pull back, make sure you're not having any blood, and pull back. But the trick to this injection is that you're going to pull the skin to the side and enter the skin, because essentially what that does is the equivalent of entering the skin on an angle. And what that provides is, if you were to enter straight perpendicular and make a hole, then you can make a canal where this fluid can drain, even though we stopped draining the procedure. You took the needle out and it keeps draining because the canal's straight out. But by pulling the skin to the side and then releasing it when you're done, that skin moves, and now it creates an oblique and tamponade type canal, so it can't really come through that hole. So don't forget to do that when you do this kind of procedure. Here I'm injecting lidocaine, and you go in a little bit, inject some, go a little further, inject some again, until you get peritoneal fluid. And you can see that the clear lidocaine became a little yellowish, and that's because we got some acidic fluid in the syringe. So now I know I went all the way deep, and this is actually my paracentesis needle. It's essentially a big IV catheter. Is probably 3 to 4 inches long instead of 2 inches long for a regular IV catheter, and it's got a catheter, so once you go in and get to this space, you thread it in. The danger of any kind of procedure like this, you're entering with a needle into the abdominal cavity. You can hit bowel and create perforation, and bacteria come from the bowel to that fluid. Patient can get really sick. So that's why you want to make sure with the ultrasound that you have the biggest pocket available for you to do this procedure. The sides of the abdomen are the best one. As you can see here, I'm using a blade. That is because the needle I'm using is pretty thick. So trying to go in, I would have to apply a lot of force to go in through the skin. And applying that force, all of a sudden giving out, I could go really deep all of a sudden. So by nicking the skin, I'm making a little space for me not have to push as hard going into the skin. And you can see, as soon as I get fluid, I know I'm in that space. And what I do is, without entering the metal part anymore, I feed in the catheter part. And you can see as soon as I pull out, there's fluid just dripping down. I mean, this fluid wants to find its way out. It wants to come out. So I have a big syringe that has 60 mLs, 20 ounces. And you can see nice, clear, urine-colored fluid. Most of the joint and acidic and fluids in the body are yellowish in nature, except for the lumbar puncture, which is the other video I did. That one's clear, but this is yellowish. It's very proteinaceous, means it has protein, so it's a little cloudy. So just the fact that it's cloudy doesn't mean there's any infection. And so I drain an initial 60, and those we get out because we want to send it to make sure there's no infection, cultures, gram stains, and so on. But this patient had no symptoms since he's had this many times, so we don't really have to send it for analysis. Other patients do, because they're having symptoms of abdominal pain or fever and so on. So then we hook up that catheter to the tubing, and that tubing will allow us to connect it to suction bottles. Suction bottles are negative pressure glass bottles that once you enter in, they suction out. They have 1 liter bottles. They have bigger ones, some hospitals, but that's the one we had available. And you don't see what I'm doing here, but I'm actually hooking it up at the other end of that stick to the suction bottles. And I'll be showing you in just a minute how that looks. And this is that suction bottle. You can see it's about a little bit more than half filled with this acidic fluid. This is our very first one. And I'm going to show you a picture that shows that when we're about the 3rd bottle into the procedure, actually 4th bottle into the procedure. So that's 4 liters so far. Each liter weighs about 2.5 pounds. So you're talking about 10 pounds of fluid removed from this patient already. That's a big deal. I fast forward a little bit so you can see the process being filled out and being changed. Yes, don't make fun of my shiny shoes. I like them a lot. There we go. So you can see the catheter, you know, it's going through, it's going into the bottle. This is 1, 2, 3, 4, 5, 6 bottles, 6 1-liter bottles, and then we use like 3 more smaller half-liter bottles. We just ran out of bottles in the emergency department, like I said. Not a very common procedure in the emergency department because we're too busy. It takes a lot of time, and usually we send them to interventional radiology where they do this, or they get admitted to a hospital and get this done. In this case, I really wanted to do the procedure because the patient did not want to be admitted. He's had it many times, so it's not like it's a new thing for him or his family. They know how to take care of this. And finally, once I'm done, of course, remove the catheter, you know, put some pressure, and most importantly, put a Band-Aid to make sure that he heals well. Say a little prayer so God's with him and doesn't get any infection or any problems. And that's it. You could literally, while you were doing the procedure, you could literally see his belly being from so big and coming down, coming down, coming down. Total, we remove 7.5 liters, 25 pounds. I try to carry all the bottles in a box afterwards. It is heavy. So I'm instructing the patient, to go and follow up with their GI doctor. I'm thanking them again for allowing me to record this video for the education of everybody, nurses, medical students, and people who need the procedure done. They can see how it's done, so their fear is less when they go to have it done. And that's it. We're done. Again, remember to clean your iodine. It can cause chemical burns. So we clean it and we're done. Go to ED Exit Video to see other videos and search